Our chief guest this morning is Mr. Shankar Agarwal, the Additional Secretary at the Department of Information and Technology, Government of India. His flight is almost arrived in Mumbai and he should be with us in the next half an hour. Till such time, I would take the pleasure of introducing Lord Nigel Crisp, an independent crossbench member of the House of Lords in the UK and works mainly on international development and global health. He is a strategic advisor to the CEO on global health and a senior fellow at the Institute for Healthcare Improvement. The former chief executive of the National Health Service, the largest health service in the world, and permanent secretary of the Department of Health. He led major reforms in the English health system. Prior to joining the NHS, he served as the chief executive of the Oxford Redcliffe Hospital NHS Trust. He also co-chaired an international task force on increasing the education and training of health workers in developing countries. Subsequently co-founded the Zambia-UK Health Workforce Alliance in 2009 to implement some of the task force proposal. He is an honorary professor at the London School of Hygiene and Tropical Medicine, an honorary fellow of St. John's College in Cambridge and of the Royal College of Physicians. He chairs or is an advisory board or a trustee member of numerous organizations, including Sight Savers International, African Center for Health and Social Development, the Global Health Program at the Aspen Institute and RAND Europe. Above all, he's been an author of the book Turning the World Upside Down, The Search for Global Health in the 21st Century. Luckily, he has some copies for us. Those of you who would like to buy them later on, you can get in touch with Lord Nigel Crisp. And may I now request him to please give the inaugural keynote address.
Thank you very much indeed for that introduction. Can I just check before I start speaking that I can get these slides on? Do I need to do anything? I have a presentation here somewhere, if someone might come and put them on while I just make a few initial remarks. So first of all, it is a great honor and a great privilege and a great pleasure to be joining you here today in Mumbai and to have a chance to set out a few thoughts on the future of telemedicine and e-health from a global perspective. Let me start by congratulating you. I don't know if you heard any of that, but can you hear me now anyway? Oh, well, good. Okay. I was just saying it's wonderful to be here. Let me start off again just by saying congratulations to the organizers. Congratulations on this terrific event, which I'm looking forward to. I'm looking forward to having spoken now, so I can now start listening for the rest of it, because there are so many good sessions coming up. Congratulations on the 10 years and your prescience in setting it up. And congratulations to the President on that inspiring speech and that story of growth and development over these 10 years. And just think for a moment where we're going to be in 10 years' time. This is an extraordinary journey that we're all on. I'm actually going to start by giving a message from Archbishop Desmond Tutu. He asked me to say this. He said, just recently the population of the world reached 7 billion. And we know the vast majority of these people are the poor without access to clean water or adequate health care. The new exciting project of e-health and telemedicine wants to change that by making use of modern technology to bring the best medical knowledge to the poor and inaccessible. And what a fantastic mission statement that is. And that's his starting point, and it's also mine. Now, you might want to ask, why am I quoting Archbishop Desmond Tutu? Well, the answer is that today in Rio de Janeiro, he is attending a meeting which I think is organized by the International Society of Telemedicine and launching an e-health global ambassadors program. It will include people like the former president of Brazil, leading figures from around the world, and in due course I know they'll be wanting to recruit one or more people from India to join. And the aim of that Global Ambassadors program is to promote e-health, to make sure that in every gathering, not just the gathering of the people who know about telemedicine and e-health, but in every gathering, people are thinking about e-health, thinking about telemedicine, thinking about its role in promoting and providing health and healthcare for the poor as well as for everybody else. And can I just say that Ricky Richardson and Yungkap Kwankum, who are part of that program, also send their best wishes to many friends in the audience here. Now, what the Archbishop has said is obviously provides a justification and a reason for all this interest in telemedicine. But there are many others, and I will just quote your chairman, Rajendra Gupta, for a moment, in the program where he says that in India, 2% of the doctors work in rural areas, yet that's where 65% of the people live. That's a profound statement about need and about how you're going to reach those 65%. Let me show you another, because I think there are all kinds of different reasons why this is important. Let me show you a simple graph. It's about health spending versus outcomes. I think we all know, don't we, that the amount that a country spends on healthcare doesn't directly correlate with the results it gets in healthcare. And I'm not looking at my American friends when I say that, but I did catch the odd eye. And this graph, which actually it came from Ricky and it came from Yungkap, in fact, shows the relationship between GDP per capita, which is along the bottom, and childhood mortality, mortality under the age of 5. And you can see that countries with similar profiles in terms of GDP, those two at the top, have very different health outcomes. You can also see country A and country B at the bottom, countries with similar health outcomes, but very different spending profiles. That's actually a 1,000-fold difference. These are astonishing differences. There's no relationship that you can discover, broadly speaking, between health spending and health outcomes. So it is crucial that you understand, that we understand how to spend the money properly. And this is going to be a theme, I suspect, of this conference, is how do you use this wonderful burgeoning field of telemedicine to get better value? Not just for people in low and middle income countries where every wasted rupee or wasted dollar is really a tragedy, but also in rich countries where we waste quite a lot of dollars and pounds and occasionally, no doubt, rupees. So lots of pressing reasons why telemedicine is so crucial. What I'm going to talk about is the global context, but also comment on some changes in the NHS, which, as you know, I used to run, which I think have some relevance here. Let me start just by looking back at the last century when we didn't really have e-health. Last century was a terrific century in terms of health. Life expectancy for somebody in a rich country, if they were a man, went up from 49 to 79 between 1900 and 2000. That's 30 years in a century. That's 3 years in a decade. If you want to look at it another way around, it's 8 hours a day. Astonishing improvement in life expectancy. Whether or not you wanted that 8 hours probably depends on what sort of day you had. But it really was an extraordinary set of changes. But life has moved on. Life has changed. The problems we're dealing with have changed. This map, which many of you will know, which shows the size of countries in relationship to their burden of non-communicable diseases, and I hope you can see it. It's not terribly clear. But you can see how the burden of non-communicable diseases has distorted the shape of India. This is your big problem, and I know your government's #1 priority, isn't it now? But look at the the UK, that fat blob in the middle. India and the UK share a great problem with non-communicable diseases. They are the diseases of the 21st century. They are the issues we're going to have to deal with. And what's interesting is they are very different from the diseases which we actually dealt with for much of the 20th century. They're not about episodic care, going into hospital, being killed or cured with hospitals and doctors. They're about a lifetime of a disease. When we may go into hospital for a period, we may be cared for in the community. We may be cared for by our family. We may be cared for by our neighbors. We may have acute episodes. We may have periods when we're very well. It's about prevention and treatment. It's a very different course of treatment. And that is something that we have to tackle in the 21st century. And it's one of what I call 4 great disruptions in the 21st century. Why healthcare is more problematic and different from the 20th century. Why the future is not like the past. The first one is diseases have changed. The second one is patients and the public have changed. People are not so deferential. They don't necessarily do what the doctor tells them. But of course, we are all both part of the problem as well as part of the solution, because so much of this is about behavioral aspects. The third great area of change is that science and technology are developing. I don't need to tell this conference, and I don't need to say how the confluence of what's happening in ICT and the new biology is providing extraordinary insights. And I speak as somebody whose son is a computational biologist who brings those two things together and tells me that I don't understand it at all. But there's a lot of the future that is in that set of interconnections. And we don't know what they're going to feel like. We don't know what we're going to be doing with those things in a few years' time. But the fourth great difference is our global interdependence. We're interdependent in terms of the fact the same diseases will come and get us. In the 14th century in Europe, it took 3 years for the Black Death to get across Europe. In the 21st century, it took 3 days for SARS to get around the world. We're vulnerable to the same diseases. It is important to us that every part of the world spots those diseases, has good surveillance and so on. We're as vulnerable as the weakest part. But the global interdependence is also shifting. Power is shifting. Again, I don't need to say that in Mumbai, do I? The world is changing. The great global institutions are changing in all kinds of ways. And what's also happening in these countries such as India, which are getting bigger and richer, is that you're reaching what has been called the economic transition by people like Ariel Pablos Mendez, which is when a country gets rich enough, people start demanding healthcare. You see it in China. 2 years ago, they set up a program for a national health system. You see it in your country, of course, and I'll say another word or two about that. You see it in South Africa. We really are now, as a world, trying to get healthcare to the poor and to people around the world. These are big and profound changes, and big and profound changes which can be addressed in part through telemedicine. But to address these issues, you need to look at innovation and ideas from rich countries and from poor. Let me just touch for a moment on, my book was very kindly mentioned, Turning the World Upside Down, in which the argument is there's a lot that rich countries can learn from low and middle income countries. And part of it is about engaging people and communities. If we're going to tackle these new diseases, if we're going to work with the public, we have to know how to engage people and communities. I've visited in Rajasthan a group called Urval, U-R-V-A-L, a cooperative of weavers, as it happens, who have set up a set of health programs. I visited BRAC in Bangladesh and seen how they, again, whose primary focus isn't health, have actually started to develop and had, over many years now actually, a really big impact on health because they bring together families, communities, women in particular, and they bring health together with other things. I also see around the world people restructuring the health workforce. Big issue this. If you're interested in costs in healthcare, well, 60 to 65% are in staffing. So if you're going to actually manage your costs, you've got to manage your staffing costs. And I see in places like BRAC, I see in places like Urval, I see in places like Aravind, people deploying staff in different ways than they do traditionally in Germany and France and England and the US and so on. And we need to learn about how and in what conditions mid-level workers, semi-skilled professionals, non-professionals can actually work effectively. And we can take examples like in Mozambique, where in Africa, I think they've done even more of this. In Mozambique, effectively, the cesarean operations outside the capital are done by nurses with additional training. They do them as successfully as doctors, and they do them at half the cost. These are all profound changes that we in rich countries can learn from. We won't necessarily copy what others are doing, but actually they challenge our received wisdom. But then, of course, the science. A lot of the science and knowledge is going to come from the laboratories around Europe and America. And that's why I think we should be talking about co-development. We're in this together. It's about global interdependence. So we've seen with telemedicine an extraordinary flowering over the last 10 years. I think, again, Rajendra, in his opening comments in the program, talks about 10 different ways of telemedicine can make a difference, raising healthcare awareness, about education and prevention, about remote monitoring, about telediagnosis, about management of chronic disease, home care, rural health, teleconsultation, and so on. I'd add some others. I'm privileged to be involved with an organization in the UK called Doctors.net. It has 180,000 doctors as part of it. That's 95% of the doctors registered in the UK. It's a service purely for doctors. Nobody else can join it. It's a service in which doctors can talk to each other. There are forums. It's a service in which doctors can put up a problem and say, I saw 10 minutes ago a woman with diabetes, age 40, with these sort of circumstances. This is what I did, but I'm worried. It doesn't feel right. What do you suggest? And within an hour, you'll have 10 replies from named doctors from named institutions offering advice. The person who invented it, a young man, because most of this is coming from young people, isn't it? It said that he was trying to recreate the junior medical doctor's mess, where you could actually consult with colleagues and say, I think I made a mess of that, what do you think? You know? But you probably need to be just careful about where the lawyers are in all of this. But maybe we'll come back to that point as well. But an extraordinary organization. And that sort of ability with telemedicine to give solidarity, you as a profession, I think there's a lot of doctors in the room, love talking to each other. All professions do. And the ability to buddy with people across continents. So the isolated doctor in Africa or in rural India can be in touch with his or her profession and feel they're part of the global movement of improving medicine. So much of that flowering that can happen and that is starting to happen. Now, this conference was entitled The End of the Pilot or something of that sort. It's the right question. I think of it as the coming of the age, the end of the pilot phase. Telemedicine now needs to get really serious. You know, the exciting pioneering bit will still carry on. But actually, you have in India, we have in the UK, non-communicable diseases to sort out. People don't yet know how to deal with them. Telemedicine can make a contribution. You have in India the Planning Commission, chaired by your Prime Minister, where has a report going to it very shortly, led by, indeed, a good friend of mine, Srinath Reddy, who many of you will know, proposing changes for the next 5-year plan about developing a much more comprehensive health system for the poor and for, indeed, everyone in this country. How is telemedicine going to help make that happen? Really important challenge. Telemedicine needs to be mainstreamed, interconnected with everything else. It needs to be about building capacity. It needs to be about available to all, so that when you in this great country are making the great strides that you are, you're not leaving anyone behind. That's the challenge. That's the sets of challenges. These are really difficult issues. But there are examples where I believe India can lead the world for all kinds of reasons, including the energy and enthusiasm in this room. But to do that, you need a change program. You need to make massive change on a massive scale, and not just in the technology. Let me illustrate it with something that I know about, which is the changes we made in the NHS, and just touch on them very briefly. We made reforms in 4 really significant areas. Copies of this slide are available, because I imagine it's probably too small to see properly in the back. The top left-hand quadrant, we redesigned services. We had a quality framework, we created new delivery channels. Some of them were e-orientated. We had NHS Direct, for example, 24-hour free telephone service where you could ring up and talk to a nurse, and NHS Direct online. We've invested very heavily in primary care, but we started to change the way services were delivered. In the next quadrant, going round clockwise, we actually realized that it wasn't just enough to change the services. You've got to change the incentives in the system. You've got to change the way the system works. We introduced competition. We gave patients choice. Patients could choose which hospital they went to. That started to change services because it provided a feedback loop into that. So fundamental big changes there, decentralization, and we changed the payment system. Coming round, we came round to staff restructuring. This is the one we did least on, but is probably the most important. As I said, 65% of our costs are in staffing. But if you're changing the service, if you're changing the way the incentives work, then you sure as need to change the structure of the organization, the skill mix of staff, the job design and the job roles. And this is where the biggest element of opposition will come, of course, from those working in the traditional professionals in particular. And coming around to the fourth quadrant, we also developed much better access, particularly to knowledge. Really interesting work about the NHS electronic library, for example, about the use of NICE, the National Institute for Clinical Excellence, to try and sort out what technologies, what therapies worked, and what worked better than other therapies. Knowledge being really fundamental as part of the future. Now, you can look at that picture and you can see how redesigning services, redesigning the whole system, redesigning jobs, redesigning how you access knowledge. Well, isn't the scope for telemedicine in every one of those quadrants? Most fantastic range of things that can happen. And if I just take that one of knowledge just by itself, I heard from Atul Gawande, a great Indian, of course, living in America, or now an American, that he quoted that there are now 13,000 recognized diseases on the ICD register. There are now 6,000 different operations. The old model of 50 years ago, perhaps where the doctor knew it all in his head, has rather gone, hasn't it? You've got to have access to information. You need it now. So the world has changed, and this is the sort of set of reforms we did in the NHS at a point when we were trying to revive the NHS in the year 2000. And indeed, we were very largely successful, and patient satisfaction and public satisfaction with the NHS doubled in a decade. So we had a big impact by addressing these reforms. Let me use that same model then just to think for a moment about the future and think about the use of telemedicine in the future. So let's look in those quadrants, because I think these quadrants apply. So if you start off with service redesign, well, actually, one of the issues of service redesign is it's got to be really around the patient. And whilst people may be collecting information in this institution and in that institution, and patients may visit different institutions, those need to be joined up. You get into all the issues of interoperability. But actually, if I'm also right, that we've got to be thinking about the determinants of health, as well as the healthcare aspect, then maybe we've got to start to pull together a wider range of information. Information about income, information about employment. Because actually, you know, if you're working in healthcare, that those things affect the patient in front of you, and not just the genesis of their disease, but actually their ability to deal with it. You know, economic status is as important as anything else. So there's a real issue about redesigning services around the patient in that very wide sense. Interoperability. And also, point I've written down here, who owns the patient record? We had a bizarre situation in the UK where patients couldn't see their own patient record, yet it was their patient record. And then we had a system whereby you could only see it if the doctor had cleaned it up, and he was given about 3 weeks' notice, and he could take things out if he didn't like what he'd written in it. This is an absurd approach. Now, with e-communications, e-technology, the patient record needs to be owned by us as individuals, wherever we can. Seems to me a really fantastic and fundamental change in how we are doing things. Now, I know people will complain, but actually, take a country like India, a lot of people won't be able to do that. Well, maybe that's true. Maybe it's not true. You know, I don't know what pace you thought mobile phones were going to spread around the world. You know, maybe we patronize people too much on some of that. But maybe there are risks in assuming that. But maybe there are worse risks in staying with the old system of doctor knows best. You know, nothing is without risks. So big changes around service redesign. But what about the changes around system redesign? Because what you're doing is a real challenge to hospitals, isn't it? And to current payment systems. I know in the UK we find it very difficult to work out how to pay for a telemedicine consultation. Particularly if the telemedicine consultation means that nobody goes into a hospital or goes and sees a doctor and so on. And what about the secondary consultation? How are you going to get the payment systems for this right? How are you going to get the liabilities issue right? I already joked about the fact that, you know, if lots of people are giving me advice as a doc over the internet, who's to blame if it goes wrong? Well, there's something even more fundamental than that. As a young friend of mine, Alexander Finlayson, who runs a thing called Medicine Africa, says, he says, anyone can create an app. Anyone can create an app which will have an effect on how people treat people in healthcare terms, but not anyone can create a drug. There's some need here for some kind of careful thinking about regulation, because that app may be as dangerous or as beneficial as a drug applied well or badly. And there's, as I say, that real issue of challenges to hospitals. You know, you're the hospital chief exec, you're tight for money, you've got a staff who depend on you. How welcoming are you going to be of some of these things that are going to take away some of your work? Because some of them are. Let's be realistic about that. Let me move on round to the staff restructuring. Now, I've already talked about that. But as technology grows, we've seen it, of course, already, haven't we? We've seen many things transfer from one group of professionals to another. We think of things that used to be done in tertiary or even quaternary services now done in secondary care and maybe now done in primary care. We've seen that sort of move. We've seen how difficult it is for cardiac surgeons, certainly in the UK, to see some of their work disappearing into somebody else's cath labs. You know, the sort of pressures. I remember one elderly cardiac surgeon, elderly, he was my age, cardiac surgeon saying to me, yeah, it's a real shame for these young chaps, you know. They can't cut people up in the same way as we do, you know. Well, yeah, sure it is, but it's even better for the patients if you can do it in a way that's perhaps a bit more evidence-based. Skill mix will have to change, and not just in a sort of negative way. I think the professions and professional training is going to have to change to pick up these methods, but also so that the professions, the higher professions, the doctors and nurses, recognize that their role, as was said in the Lancet Commission on Education and Training of Professionals in November last year, it's going to have to be about leading trans-professional teams, not just teams of professionals, but actually in the nursing environment, it's the nursing assistants as well. It's the mid-level workers. It's, you know, why do we take 9 years to train somebody to do cataract operations?